Assalamu alaikum. I'm Dr. Nas and I'm again here with the topic of stable ischemic heart disease and stable angina. We have done the non-invasive investigations and the invasive investigations, clinical presentation, pathophysiology, and about the symptoms and all the clinical examination of the stable ischemic heart disease patients. Now we will move towards the therapy and the management of this stable ischemia. So I will try my level best to make you understand and to make your things more clear about the stable ischemia. So we need to start from treatment. We have to start from the aspirin. So as you know that aspirin is the heart of cardiology. It's actually the pivotal medication and the important medication in the cardiology. Cardiology is nothing without aspirin. So it is class 1 in stable ischemic heart disease patient up to the indefinite period. Either you have done the intervention or not, this aspirin is class 1 in ischemic heart disease as well as acute coronary syndrome and the stable ischemia. Second thing, now we and the trial which actually supports the aspirin, there are so many trials. Those were the current OSS, ACS, and there are actually so many meta-analysis on this aspirin which told and which actually showed the mortality benefit with the aspirin in stable ischemic heart disease. Now we will move towards the important thing which is very much important for us, that is the P2y12 inhibitor. So what is the role of P2y12 inhibitor in the stable ischemic heart disease without intervention? Make this thing clear that should you give the P2y12 inhibitor, clopi, as we have discussed this in our acute coronary syndrome lectures, that we have three or four, actually 3 oral P2y12 inhibitors, Tika and Presu. So keep this thing in your mind that you cannot give the DAPT, like dual antiplatelet therapy, in stable ischemic heart disease patients who are on conservative management, who are kept on medical management, and or those patients which haven't gone for the angiography or angioplasty or stenting. So there is no role of P2y12 inhibitor stable ischemic heart disease who are kept on the medical therapy, and the trials who actually support this, who actually showed that there is no mortality benefit of giving the P2y12 inhibitor in stable ischemic heart disease, that was the charisma. Actually that is a negative trial for DAPT in the stable ischemic heart disease. Now we have to discuss that those patients who have stable ischemic heart disease patient but have gone for the PCI, with either BMS or DAS. Got it? So that is the important thing, that those patients, patient stable ischemic heart disease, now they have gone for PCI, either DAS or BMS. You know that these are the two variants of the intracoronary stents we have, that DAS and the BMS. Okay, so if you have gone for the PCI in the stable ischemic heart disease patients, you have the only one P2y12 inhibitor which is actually recommended by the guidelines of ACC and AHA, that is only and only clopidogrel. You cannot give ticagrelor and pasugrel in the stable ischemic heart disease patients who have gone for the PCI, because you have the only drug for the stable ischemic heart disease, that is the clopidogrel. Either you have gone for DAS or BMS. If your patient have not gone for the like for the elective PCI in the stable ischemic heart disease, you there is no need to give the P2y12 inhibitor in your patients. So keep this thing in mind. That is very, 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 very important concept. Now, what would be the duration of DAPT? If your patient has gone for the PCI with DAS, then you need to give DAPT like aspirin plus clopi, this DAPT up to 6 months. This is, and that is the class 1 indication in your patients of stable ischemic heart disease have gone for the PCI. But if you have put BMS in your patients with the PCI and stable ischemic heart disease, then that DAPT would be not more than 1 month. Got it? Not more than 1 month. So now the important thing is, if you want to continue DAPT for longer duration, so whose patients, what type of patients, and what would be the clinical features in which you have to start the DAPT for the longer durations. So yes, now for the continuation of the DAPT for longer duration in your patient of the stable ischemic heart disease or acute coronary syndrome. In acute coronary syndrome, if you want to give the DAPT longer than the one year, or in stable ischemic heart disease, if you want to give DAPT more than 6 months in DAS and 1 month in the BMS, so you need to calculate the DAPT score. Now, what is the DAPT score? It is very, very, very important score. So first component of the DAPT score is age. If your patient's age is more than 75, then you will give -2 point to your patients. If the age of your patient is 65 to 74, then you will give the -1 point. And if your patient's age is less than 65, then you will give it 0 point. Okay, what else we have? If your patient is smoker, give it +1. If he or she is diabetic, give it a 1 +1. If your patient has prior MI, give it a +1. If your patient has stunt dia, which it means that your patient had already gone for, if your patient is already status post primary PCI for any reason, and the stunt which he or she had in the coronaries, and the dia of that stunt is less than 3, then you will give it +1. And the older generation paclitaxel DAS, drug eluting stents, is used in your patient, then you will give it a 1 point. If your patient has EF less than 30, you will give it a +2. And if your patient has venous grafts, it means that your patient is status post cabbage, then you will give it a +2. So you will these all are the components of the DAPT score. Score. So you have to calculate the score according to these components. And if your patient has a score less than 2, then no need to give the DAPT. If it is a score of more than 2, then you need to give the DAPT. So it is that simple, that if your patient is diabetic and smoker and he is a younger patient than 65, it means then you can continue your DAPT in your patients of stable ischemic heart disease or ACS if you want to continue for a DAPT for the longer duration. But if your patient has a age more than 75, then obviously it has a -2. So if your patient is 75-year male smoker and diabetic, there is no need to give the DAPT for the longer duration. But if your patient has 75, smoker, diabetic, have the prior MI, and EF is less than 30, then obviously that patient's score would be more than 2, then you can continue the DAPT score. So like this we have to calculate the DAPT score in our patients. I hope that you will practice this score in your clinical practices or the bedside with your patient. It's a very wonderful score to give you the good guidance to continue the longer DAPT for the longer durations. Now if you will ask me that can we give the TICA in stable ischemic heart disease, then there is a negative trial, that is a Pegasus. Pegasus is negative trial. It told us that TICA is not beneficial in stable ischemic heart disease. So you cannot give the ticagrelol in any sort or in any condition in stable ischemic heart disease. Either your patient have gone for the PCI or not, you cannot give the TICA. Okay, so Pegasus actually told us. Now we come to antithrombotic therapy, the very recent trial. These things yet to be become or yet to be recommended by the guidelines, but as we know that we are cardiologists, we have to be up to date. We have to be up to date for our patients. So if you go or read the up to date, you can find all these things, that what is recommended or trial based antithrombotic therapy in stable ischemic heart disease. So in stable ischemic heart disease, they actually Compass, the recently came trial in 2018. Compass trial told us that you have to give rivaroxaban, which is actually 10A inhibitor and an antithrombotic therapy obviously agent, and it if you give 2.5 BD with aspirin in stable ischemic heart disease patient, actually you would give mortality benefit. So mortality benefit has been shown by the Compass trial in stable ischemic heart disease with rivaroxaban 2.5 twice a day with aspirin. So yes, if anyone asks you about the antithrombotic therapy, yes, there is a trial based or trials recommended therapy of antithrombotic therapy in stable ischemic heart disease, that is a rivaroxaban, and the name of the trial is Compass. Okay, so we have done the aspirin, we have done the DAPT, we have done the antithrombotic. Now come to statins. So as you know that statins are the important thing. Why? It has an it has an anti-inflammatory role, and you know that the atherosclerosis is sort of an inflammatory process, so you need to stop or inhibit it by the statins. So we what sort of statins we have a lot of class or a lot of agents for the statins. We will discuss here very few, and you know that the important one is like atorvastatin and rosuvastatin, because these are statins who are high intensity statin, and in stable ischemic heart disease or in established ACCVD disease, atherosclerotic disease, you have to give the high intensity statins according to the recent guidelines. So you have only two agents, atorva and the rosuva, two agents recommended by the guidelines, high intensity in your stable ischemic heart disease patient. So what else we have? Like we have a very older trials which is written in your book, that is the HPS trial. HPS trial is on HPS trial is actually on the parva and lipid and HPS trial is on parvastatin, and 4S is on simvastatin. Okay, so atorva has prove it to me. Rosuva has Jupiter trial. Okay, so these all are trials of your statins, so you can quote these trials while prescribing these things. Okay, so the guideline says that if you want to so what is a high intensity? Actually high intensity, we just discuss little bit these sort of things here, and then we will move forward. So what is a high intensity statin? High intensity statins are those statins who actually has the capability to decrease your LDL by 50%. For suppose if your patient has LDL of 160, so you need to reduce it by 80. And for suppose if your patient has LDL of 100, it is more or less a normal range. But if your patient has LDL of 100 with stable ischemic heart disease or acute coronary syndrome, then you need to decrease it at least by 70. At least you need to keep the LDL level of your diagnosed ischemic heart disease patient less than 70. So many trials actually showed that if you can decrease the LDL of your patient less than 25, there is no harmful effect of decreasing the LDL at least up to the 25. But guideline says that if your patient has a LDL in normal range and patient has even though patient has stable ischemic or sort of the acute coronary syndrome, then you need to keep the LDL less than 70. So what else? If your patient is on the maximum high intensity therapy like Rosuva, Netorva, and still your patient has a high side of higher levels of LDL, despite of his compliance and each and everything, then you will ask about the affordability and all these things, and you have to add the ezetimibe. Okay, ezetimibe is actually an additional to is addition to the statin, and it further decreases the LDL. So ezetimibe, and the trial which actually showed and which actually recommended this drug with the high intensity rosuvastatin and higher level of LDL cholesterol despite of optimal medical therapy with the statins. That trial, the name of this trial is Improve It. Okay, so Improve It trial actually Improve It trial actually came with the recommendation of the ezetimibe in the ischemic heart disease patients. So which are those patients who will have the maximum benefit of the statins in the stable ischemic heart disease? Obviously those would be the patients like history of 65, more than 65, history of MI, CVA, PAD, peripheral arterial disease and metabolic syndrome, raised CRP more than 2, and coronary artery disease more than 40% on angiography in stable ischemic heart disease. So these are the actually patients who would be maximally benefited with statin therapy. Okay, so if your patient has these like clinical components, or if your patient is more than 65 or he or she has a history of MI and the metabolic syndrome, and if you and if you have gone for the CRP and it is raised, so surely you need to put your patients on the statin therapy. Okay, now we will move towards further which therapies we have. Nitrates. Obviously you know that you need to treat your patients on medicines with stable ischemic heart disease, and you need to optimize the medications. Obviously without nitrates you cannot optimize the medical therapy in your stable ischemic heart disease patient, because they would be complaining for the obviously chest pain. So the nitrates, obviously what nitrates do in heart patients, it actually decreases the preload, okay, preload and work of heart. By decreasing the preload, it is actually decreasing the work, and by decreasing the work it is actually decreasing the demand of heart. Okay, first thing, and second thing actually they do is that they actually are very good vasodilators, so they actually increases the blood flow. by vasodilation in coronaries. Okay, and the third one, it actually decreases platelet aggregation. So it is actually what they do, they decrease the platelet aggregation and thrombosis, and it actually prevents your patient by from developing from the development of thrombosis. So nitrates are actually beneficial drugs, but it has no proven mortality benefit. Okay, so what are the side effects of the nitrates, and should how we should use these drugs in our patients? So first of all, obviously you need to give the nitrate free period, because if you will not give a nitrate free period to your patient, so your patient would have a tachyphylaxis, and then that means resistant to nitrates. So you need to give it nitrate free period. For suppose if you are giving nitrates in morning, then you need to give it in evening, then you need to give a nitrate free period of at least 8 to 12 hours to your patients, and then again your patient will take the nitrates in morning and evening, but not in the night. So you need to give a nitrate free period to your patients. And what are the consequences or side effects of nitrates? Obviously your patient would complain for the headache, because it actually increases the vasodilation, increases the blood flow to the brain. So it increases your patient would complain for the headache and flushing, and your patient would complain for dizziness, weakness. Okay, and your patient can also complain for a postural hypotension, because it actually increases it increases the pooling of blood in the veins. So it actually decreases the the preload of the heart. So yes, but it has a drug interaction as well. If you are giving it with and other vasodilators such as the AC inhibitors or hydrolazine, so they can actually worsen the effect of that. It can actually it actually worsens the postural hypotension and symptoms of or like side effects of the nitrates. That's why you need to give these medications very carefully in those patients who are on nitrate therapy. So these are, and a few of medications are absolute contraindication with the nitrates, such as the sildenafil and tadalafil, because they actually decreases the blood pressure on very it actually decreases the blood pressure too much. That's why. So it is absolutely contraindicated in the patients who are on nitrates. So you cannot give the sildenafil and tadalafil to your patients. So what else we have? Obviously the most important group is beta blockers. You know that beta blockers have mortality benefit in stable ischemic heart disease as well as the acute coronary syndrome. So there is the proven mortality benefit in stable ischemic heart disease of your patients. So you have obviously two classes here, is obviously beta 1, beta 2 and mix both. Okay, so the most specific cardioselectives we have metoprolol and metoprolol, atenolol, bisoprolol and nebivolol. But this nebivolol has some alpha activity, because it is proven by the research that it also gives some vasodilatory effect. That's why we use it in patients who have complaint of impotence or decreased libido because of the beta blockers. So we are now moving towards the side effects of the beta blockers, as we have discussed that these were the cardioselective beta blockers. So, and they are actually important because they are the cardioselective, so you can easily use in your patients with like if you want to prevent your patient with the other beta adrenergic receptor, the extra effects of the beta adrenergic receptor, so obviously you will give your patient these cardioselective beta blockers. Now yes, now what are the side effects? Obviously beta, you know that it causes bronchoconstriction. Okay, bronchoconstriction, so you cannot give all these things in your patient with a history of asthma. It causes the somnolence because those beta blockers who have a lipophilic activity, okay, so they cross the blood brain barrier and causes the somnolence, depression and lethargy. So they also cause symptomatic bradycardia, as you know that it has a negative inotropic, chronotropic and dromotropic effect. So it actually causes what? Bradycardia and sometimes cardiogenic shock if you will use it in an excess amount. So yes, but one thing more, it actually alters your lipid profile. It increases the LDL and decreases the HDL in your patients, but even though you need to give beta blocker in your heart patients because it has more benefits than risk. And yes, it has also hyperglycemic effects. The most important for us to counsel our patients while starting the beta blockers, we have to counsel our patients about the decreased libido or impotence they would have faced while taking this beta blockers, because it actually causes the libido and decreased libido and impotency. So the only drug which actually cope up with this situation, that is the nebivolol, because nebivolol has the vasodilatory effect. So it actually no, it has not actually that effects of decreased libido and impotence because of its vasodilatory effects. So these are the actually things. So which beta blockers should be given or which should be preferred in the heart patients? That would be obviously cardioselective most of the time with normal EF. And it also the choice and the preference of beta blocker, it is also depend upon the situation and the clinical condition of the patient. Okay, so but we are here generally talking about the preference of beta blocker in the heart patient. It should not have an intrinsic sympathomimetic activity, ISA. So who are the agents who have an intrinsic sympathomimetic activity? That is the acebutolol and penoidolol. So try not to use these agents in your patient with ischemic heart disease because it is an intrinsic sympathomimetic activity. That's why. And lipophobic, hydrophilic. Okay, why? Because when they would be lipophilic, they would cross the blood brain barrier and causes the depression and all these things. Now we will discuss the calcium channel block.